NEI Spring Congress attracts the world's best faculty to teach clinicians like you psychopharmacology essentials according to adult learning principles. Register today to join leading experts at our 8th annual event, being held May 8th through the 10th in person in Philadelphia, where I was born and raised, and via simulcast online. Use discount code NEIPOD25, that's NEIPOD25, to save $100 on your registration at nei.global/SP Congress 25F. That is nei.global/SP Congress 25F. Discount good on new registrations only.
Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, Chief Medical Officer of NEI. And today I feel a little bit guilty because we are doing our first podcast since we've been doing these for over 4 years. We've never done a podcast before on ECT. So today we have to talk about ECT. And with us, we have certainly quite an expert, Dr. Descartes Li, who is the head of the ECT service and bipolar at UCSF. Descartes, how are you?
I'm great. Thank you so much for inviting me. This is a wonderful opportunity. Thank you.
Yeah, thank you for coming. And I think that I have to be honest, I don't think at our NEI meetings we do a good enough job talking about ECT. It's sort of always there on the list. At the end of the talk, we'll say, and of course there's ECT and things like that. But as you and I were mentioning earlier, it's kind of an oldie but a goodie. Why is it hung around so long?
The trials really do show that it's one of the most effective treatments for treatment-resistant depression. And there isn't a lot of press in it. Big Pharma doesn't make a lot of money from it. And despite that, it's actually one of the more common procedures in the United States. I don't know if you know this, but it's more common than coronary artery bypass or hernia repair surgeries and stuff like that. Yeah. Well, part of the issue is I think about 100. I'm looking at the numbers. It's 100,000 people in the United States get ECT per year.
Wow.
So maybe it's 50 to 100,000, depending on the numbers you look at. But if you think each person probably needs to get, on average, 10, let's say, treatments, you multiply that out, you get a lot of treatments. And I see. It actually is a really common procedure. And, anesthesiologists are very familiar with it because they're doing a lot of them,
I have to tell you, I'm actually quite surprised by that. That's really fascinating to hear. You're right also that there's not, like with TMS, there are TMS machine makers actually that sponsor education. You don't see ECT machine makers promoting or sponsoring things for some reason. Yeah.
There's only 2 companies and they probably spend a fair bit of their budget on legal challenges from Scientology groups kind of thing. So that's my theory at least. So there's not a lot of extra money for them to sponsor these really mega trials like they do in pharma.
So is that still an issue, Descartes? I mean, are there still lawsuits and people protesting this?
There's not. I don't see people protesting, but every once in a while you hear there are lawsuits that are brought on by different groups, sponsored by different groups that advice. So, ECT doctors also, some of them make their living by, or former ECT doctors make their living by being deposed on these legal things,
Yeah,
so,
it's a shame. Why? When I trained, we were trained that ECT was kind of the penicillin for psychiatry, that it was almost as effective as penicillin for strep throat. Why is it that there is such a pushback here, do you think, for a treatment that's so effective?
Well, I think there's a lot of stigma. I mean, long ago, people were just, I say people, I mean psychiatrists and mental health practitioners were just using it pretty much indiscriminately. And if you imagine in the days before they had antipsychotics, that's all they had. And it did work for a fair number of patients. So, but, then I think over time it kind of gotten indiscriminately a little bit too much. And so, there's been kind of a backlash, but now I think we're heading into another era of, more openness to it. So I don't see as much stigma around it. It's interesting because the younger folks, we have a fair number of younger patients too. They may not have heard about the stigma so much.
Yeah.
So kind of an interesting thing.
Yeah, of course, in the pre-modern anesthesia era, a lot of the ways they induced seizures and things were maybe a little even barbaric.
Yeah.
And then, of course, there was the famous movie with Jack Nicholson, One Flew Over the Cuckoo's Nest, that didn't help us very much, but that was many years ago. So you're right.
Although I would say, if you watch, sorry to interrupt you here, Andy, but if you watch the One Flew Over the Cuckoo's Nest, the character of Jack Nicholson, he's fine after the ECT, actually. He's joking around with this. He pretends that he's like stunned or like
you're right.
Zombie, but he's actually totally fine after the ECT.
Right. That's a good point. Excellent film criticism there. But I think also what's helped, as you've said more recently, is a lot of awareness around depression, but especially treatment-resistant depression, and how hard it is to treat. And of course, with a form of ketamine actually being FDA approved, I think the idea of crossing over from a treatment modality that may be a different field of medicine or not in our normal wheelhouse, all of those things may contribute to a renaissance or a less stigma, at least for ECT, I hope. Yeah. Well, let's talk a little bit about using ECT in clinical practice. A lot of our audience may not be, of course, practitioners of ECT themselves, but certainly I would hope they would consider referring and finding a good referral source. So what are the primary indications for ECT? When would a clinician be thinking about this to refer a patient?
Thank you. The most common indication is treatment-resistant depression. And so that, by and large, would probably, in most practices, make up 80 to 90% of the folks. Now, sometimes, and it works equally well for people with depressive episodes from bipolar disorder or from unipolar depression. So,
I was going to ask
when I say treatment-resistant depression, I said sometimes it can also be used for mania, although I think our medications tend to be pretty good with mania, and if they're not working that well, the consenting process, at least in the state of California where I'm from, is a challenge. So if the person doesn't want to do ECT, it's really a challenge. So, but people with bipolar disorder, and particularly sometimes they have those severe mixed episodes that are sometimes initially diagnosed with as major depression, but really they're kind of a mixed episode. ECT can be super helpful in those situations because other meds often don't have a great track record with that.
That's really well said. If I could just highlight that for 1 minute. The idea of the syndrome of depression, a major depressive episode, which in the DSM is defined the same way, strangely, whether it's unipolar or bipolar. So perhaps I like the idea of treatment-resistant depression syndrome, if you will, or episode, whatever the underlying diagnosis is. That's helpful.
A couple of the other, another thing we're seeing a lot more of is catatonia as an independent condition.
Yes.
So it's a really interesting thing that, now again, I should emphasize ECT isn't first line for any of these, depression or for catatonia or anything like that, but
of course.
It can be really helpful for, we're recognizing catatonia, and after they get through, a fair number of individuals don't respond to benzodiazepines or respond only partially, or it kind of wears off after a while. People develop tolerance or habituation to benzodiazepines, so it can be helpful there.
Well, if I could stop there, I recently recorded a podcast with a colleague from UCSD on catatonia, and to be honest, Descartes, that's another area that we haven't talked about a lot, and it's more common than we realize, and I learned quite a bit, and she did definitely mention ECT, so thank you for mentioning that. Yeah.
The main challenge with catatonia and ECT, a lot of times, if the patient is incapacitated, they're not able to give informed consent. It's a big hassle to get a court order, as you might imagine.
Yeah. And then you mentioned there's another or other indications?
Schizophrenia is something else that we see as less common. And I think it doesn't work. It doesn't cure schizophrenia. Like it kind of, you feel like sometimes with people with depression, it's just, okay, they're cured. They're back to their usual selves. But with schizophrenia, they get improved, but you don't see the same like complete resolution of symptoms like you do with depression or mood disorders.
What specific symptoms with schizophrenia? Are we talking positive symptoms, agitation, aggression, negative symptoms? What are we talking about with schizophrenia?
It seems like more the positive symptoms, similar to what medications do.
Okay.
There's a small trial looking at people who are treatment resistant to clozapine, individuals who have schizophrenia who have been on clozapine and hasn't worked. And it shows some improvement in their symptoms, but again, like I said, it's not a complete resolution.
Yeah. How about for negative symptoms, which have an overlap with depression? I wonder if it could be useful there. I don't know if it's been looked at.
It's hard to read looking at the literature, it doesn't seem to respond as well to negative symptoms. Don't seem to respond as well to anything, basically.
Yes, that's true.
So it's a real challenge. There's some people have hypothesized that it might be useful for negative symptoms, or in the case of younger adults, if you use ECT in some of these trials, they hypothesize that maybe that individuals who've had ECT in their past may have a better prognosis.
Okay.
We can talk a little bit about why that might be a little later, I think we talk a little bit about the mechanism of why ECT, or maybe how ECT works.
Sure, yeah, I'm curious about that. My understanding is that there might be a literature with TMS for negative symptoms, another form of neuromodulation, but I'm not an expert in that literature, to be honest. Okay. So how does ECT compare to pharmacologic treatments for severe depression? Let's talk efficacy.
Yeah, well, typically the person in most of the trials nowadays, or more recent trials, I would say, are people who've had multiple antidepressant trials. So typically when you give another medication trial for someone who is in this treatment-resistant category, the odds of them improving are pretty low. The placebo response rates are really low. Even a new active antidepressant, the response rate is pretty low. So ECT has a response rate in kind of community settings of about 50% remission rates.
Oh, that's terrific. 50% remission. Oh, that's fantastic.
That's right.
Fantastic.
That's right.
If you think about the STAR-D study with SSRIs, we only got a third of people into remission, and only 50% responded. So
that's right.
Yeah, and that's how I was. I remember in my training, we were told it was very, very much higher efficacy overall than in general. Of course, nobody's 100%. But of course, obviously, when you're talking about the risk-benefit and the practicality of using it, there's a reason why we don't necessarily use it first or second, or maybe even third line. Are there any guidelines on how many trials of something else you have to fail before you get to ECT?
Well, there is whenever you read these studies on individuals with treatment-resistant depression, so, it's always important to read the fine print about what is the target audience and who are the subjects in the study. And typically, treatment-resistant depression is defined as 4 antidepressant trials of adequate dosage and duration.
Okay.
That's how the commonly is defined. And
for
I
ECT?
think studies do show that so that would be the target population for ECT.
Okay.
Studies would show that in that population, if you try another antidepressant, the odds of you doing well is very low, right?
Yeah. It's interesting because for pharmacologic trials of TRD, some of which I've done, we use failure to respond to 2 or more antidepressants in the current episode, but that's for pharmacologic, where obviously that's different. Now, how about getting ECT, just nuts and bolts, getting it covered or paid for? Do insurance companies, I would assume, require a certain amount of failures or other things?
No, they're pretty, it's not that common a procedure. I think if you look at it, like I mentioned, it's a common procedure, but if you look at it on a regional basis, it's not that many people getting it. It's just like insurance companies, I don't know, actually, but they probably don't give you that much of a hassle if you need to do an appendectomy. They don't give you that much hassle. So the demand is not that high for ECT, I don't think. It's been pretty stable. And, most of the medical directors of insurance companies are like, okay, this person needs ECT. It's
if you need ECT.
It's not an issue, right? There's no one saying, well, this person just had a bad day and now they need ECT. We don't have too much of that, know.
Yeah, that's been my impression too. Patients I've referred or people that I know, it's gotten covered pretty well, even with Medicare, for instance. So that's less of a barrier, I guess. Okay, well, we alluded to this, but how does ECT work? What are the latest theories on what it's doing?
I wish we knew the answers.
I'm sure we don't know exactly, yeah.
Until we know exactly what causes depression,
exactly.
That way, it's going to be hard to say exactly how these things work, whether it's an antidepressant or a
Well, I think
ECT.
One thing that's clear is there's not one thing called depression. I like to say it really should be the depressions, and there are probably different neurobiologies that converge upon some clinical presentation. So to think that one modality is going to work for all depression, of course, is naive. I mean, the history of ECT, just briefly before we get into this, is really fascinating. My understanding is patients with epilepsy had seizures, and then they said they felt better, and so the doctor said, well, what if we induce a seizure in these depressed people? And some of the early ways were pretty barbaric, like insulin coma and all these other things. Mm-hmm. Am I on the right track with all that?
It's totally right. And it was backed up by some neuropathology, actually. So they looked at patients with epilepsy. They did, after they passed away, after they died, they would do, histopathology on their brains. And similarly for patients with schizophrenia. So they compared the two, and patients with schizophrenia had relative paucity of, neuronal connections in certain parts of the brain, and they had some atrophy, as you know, whereas people with epilepsy actually have hypertrophy of certain parts of the brain and neuronal overgrowth.
Interesting.
So they actually had the thought that, if we could just make, I thought what you're saying, seizures and schizophrenia are the opposite thing. And they actually did things like also tried to transfuse blood from people with epilepsy to people with schizophrenia. They had a lot of different kinds of things.
Yeah.
And they didn't, they were desperate. On the other hand, you could say it's crazy, but on the other hand, they were really trying to help their patients.
Absolutely.
And they had a really limited, from these terrible diseases, and had a really limited armamentarium.
Yeah.
Another little, I don't know if this is an apocryphal story, but the way they came about with electroconvulsive therapy, they had, as you said, medications that could induce seizures and stuff, but they were really not great. They were walking, I think Meduna was one of the early ECT practitioners. He was walking by a slaughterhouse for pigs, and he saw that they use electric prods to stun the animals. And it caused some of them to have seizures, but didn't kill them, right? Because it wasn't meant to kill them. And so he noticed that they could use electricity to induce seizures. And so that's kind of, that's maybe an apocryphal story, but it's
fascinating. Yeah. Yeah, well, medicine's full of these, chance observations, if you will. So, yeah. So what is the latest theory here on the mechanism?
Well, I don't have a great theory.
Okay.
It would depend on your theory of depression. But there is experimental evidence using neurons in petri dishes in vitro, as well as in animal models, rats or mice. I always get confused which one they use. I think it's mice. But, they can do ECT on mice, basically. And I don't think they call it, it's not a therapy, they call it electroconvulsive stimulation. And if you give electric stimulation to, neurons in petri dishes, or rodents, you can show that there are a lot of neurotransmitter changes. All these neurotransmitters pour out, neurotrophic, BDNF pours out.
Yes, exactly.
And you can also show that, neuronal neurogenesis is increased.
Yes.
So there's some truth to that, neuroanatomic findings long ago. The neurons make more interconnections with each other.
Yeah. Neuroplasticity so we're not able to is a very hot topic right now in the field. Yeah.
Right. And so the thought is that ECT can help stimulate some neuroplasticity, and that's kind of the basis for some of these hypotheses looking at early young adults who get ECT with schizophrenia, that they may have a better course in the long run. These are studies or hypotheses generated in India and places where they have ECT as a first-line treatment for schizophrenia, or more commonly used for schizophrenia.
Yes. I have been asked by clinicians from other parts of the world about ECT for schizophrenia. So, you're absolutely right. And it makes sense early in the illness of schizophrenia, you perhaps have more brain tissue, more viable brain tissue to make those connections and neuroplasticity, I guess. It's funny how our thinking about the mechanism of treatment of depression is converging around neuroplasticity. For instance, we believe that our traditional monoamine-based drugs eventually, they do it slower, may result in some neuroplasticity. Of course, that's the leading theory of ketamine, as we know. And there are various other, I just got back from the ACNP meeting where I saw some posters and some talks on some really cool mechanisms. That may, as a matter of fact, be the way psychedelics work, is also the thinking, for instance, and other things. So that certainly makes sense. And then, obviously raising monoamine neurotransmitters is a relatively tried and true theory of how some of our things work. So maybe, it's probably not one thing. It's probably all the above to some degree. It might be multimodal. It does seem a bit, what's the word? Non-specific. I hesitate to say it's like a blunt instrument. Perhaps that's a little too strong. But it does seem not as refined and targeted, maybe, as we would like.
Right. My even less refined metaphor is like, if you want to hit a target, sometimes it's easier to use a shotgun than it is to use like a sniper rifle, right? Because you can...
Yes.
If 200 neurotransmitters get released and neurotrophic factors get released, that's something hopefully good will happen.
Yes. All right. And so let's talk a little bit about the modern procedure of administering ECT. Obviously, anesthesia is involved and paralyzing muscles is involved. But to help us understand, when we refer a patient, what does that process look like?
So just the logistics of the procedure. So, everyone has to be evaluated by one of the ECT doctors, the typical consultation. That's where the patient's first kind of questions and getting to know the ECT doctor starts. So it's helpful to them to get to meet us and know that we're not like unusual individuals and stuff like that. They also get a pre-op. So there aren't that many medical contraindications to
I was going to ask
ECT.
that. I was actually going to ask that.
It's quite a safe procedure from a medical point of view. And we can go into that a little bit later, but just in terms of the logistics, what patients are often very curious about, it's very helpful. It's a series of treatments. Not all patients understand that. I mean, most clinicians, the vast majority of clinicians, I usually tell patients, typically we're looking at between 9 and 15 treatments.
Okay.
Some patients can get by with less than 9, but I try to set expectations that like 9 is kind of the minimum for the 95% of the individuals. And then sometimes you need to get a little extra, that's I put the range of 15, but it's really a range. Okay. And in our service, and most services across the United States, we've been doing them on a 3 times a week basis.
Okay, got it. So that could be
then each treatment,
3 weeks or longer of treatment.
Yeah, 3 to 5 weeks is what people have to anticipate. I often tell people it's about a 3-hour. In our practice, about 75% of the patients are outpatients. We do get referrals from our inpatient unit, which is just upstairs, which is really nice to have that, co-located.
Convenient, yeah.
And I tell usually the family members, it's about a 3-hour process from the time they come to the unit to the procedure and the time they leave. So various services do it slightly differently, but that's and then that's kind of our service. So when patients come, we ask them to come at least an hour before the scheduled procedure time, and during that time, you know how it is if you've ever been having a minor medical procedure, you have to fill out a bunch of forms, you have to change into your gown. The nurse puts in an IV, which is probably, I think, the most painful part of the procedure is get an IV placed, which isn't too bad for most people.
Sure.
Then they get an IV, and when it's their turn, we wheel them into our procedure room. And again, different places have different, physical setups, but the main idea is pre-op. Then they're in our procedure room, basically. And once they're there, they get an anesthetic, sleeping medication, which will put a very short acting, which will put them to sleep for about 10 minutes, 10 or 15 minutes.
Is propofol still the one used mostly, or something like that?
In our service, we tend to use another one called etomidate, but you can certainly use propofol. You have a good memory, Andy. Propofol is less desirable because it's pretty anticonvulsant. So
of course.
If you treat everyone with propofol, most of them will still get adequate seizures, but you'll have a greater percentage of them who may not get as adequate seizure. And there's some studies looking at seizure duration as being an important factor in the treatment.
Got it.
It's interesting because you would think that, well, seizure is a seizure. No, it turns out that some seizures are better than other seizures. So
that
anyways, we
makes
give them
sense.
a sleeping medication.
Yes.
Then once they're asleep, then we give a muscle relaxant, succinylcholine. So
it's still
people
succinylcholine.
Right, and that's very short acting. Give some little bolus. And we don't have to intubate people. We just mass ventilate them because it's only they're only like asleep and paralyzed, or I'd say relaxed because it's more not as freaky for patients. They're going to be completely relaxed.
Yes.
And it's true. We don't actually we don't have 100% paralysis necessarily.
Oh, okay.
It doesn't look so good if the person has, but we just make sure we don't want them to hurt themselves. So if a person has a little bit of tremors and stuff like that, it's not a big deal really. But you do want to blunt the main seizure effect because of injure themselves.
You don't want a full convulsion, right?
Right.
Yeah.
So then they'll be asleep for 10 minutes. We'll deliver electric stimulus to the head. And so I'm pretty blunt with patients about this. We will deliver a stimulus to your head, very brief, a few seconds. Then you'll have a seizure that lasts like 30 seconds to up to 2 minutes. And there's not really that much to see because you're completely asleep and relaxed. You won't remember any of this. After about another 5 or 10 minutes, you'll wake up and we'll wheel you down to the post-op area and you'll hang out there for another hour or so. The nurse will call up your family member and you'll be back at home.
Yeah.
So
the actual procedure itself is only a few minutes, a couple minutes there. That's interesting. Okay. And then I'm sure we're all pretty familiar with some of the side effects, but perhaps you could run down the most common side effects and how we manage them.
I mentioned like 4 main side effects. One is like headache, muscle aches, and nausea. They go through those pretty quickly because people are like, and then you get, it's not those are not deal breakers, but headache, nausea, and muscle aches. And those things we can, if you get those things, we can, give you some medications.
Sure.
Toradol to help you feel a little better, some Zofran if you get nauseous, but those are not deal breakers. The most concerning side effects are cognitive side effects.
Exactly.
So confusion. Memory problems that patients may have. And so patients will often ask me, like, how much amnesia will I get? Well, what's the likelihood I'll get amnesia? Right. It's a challenging question to answer. And I say to them this, which is like, do you remember what you had for breakfast 1 week ago? So we're recording on a Friday. So do you remember what you had for breakfast or lunch, Andy, last Friday?
Yes. No, not at all.
If you can't remember, then now some people do remember. They have the safety patient every week.
Yeah, that's true.
If you can't remember, that's amnesia. Because if I asked you right after you had breakfast, you would say, I do. I had cereal or whatever it is. But if I asked, but now you've forgotten. So that's actually amnesia, something you once knew and have now forgotten. So ECT can certainly cause amnesia. Okay. And so everyone we all have an amnesia, but we just call that normal forgetting.
Yes.
Now, ECT would accelerate that or make that worse, I would say. So I tell every patient that it can make it worse. But the advantage of thinking about it as like accelerated normal forgetting is because normal forgetting has certain rules actually around it. Like you're more likely to forget things that recently happened to you. Things that you've known for a long time, you're less likely to forget. Like people ask me, well, I forget my, parents' names.
Yeah, no.
It's like, that's unlikely. If you've known them for a long time, you're not going to forget those kinds of person you met at a party a couple days ago. That's the name of that person you may forget,
Okay,
so that mirrors more like people's personal experience also. Like those are the kinds of things you forget. So you're more likely to forget. Things that are more emotionally salient to you, you're less likely to forget because your wedding day or something like that, you might remember that feeling that you had because it's high emotion and stuff like that. So those kinds of things tend to be
I see.
Forgotten in the same way as like normal forgetting is. There is also there's just to go back a little bit, Andy, and apologies if this is going back too much for the audience here, but there's 3 steps to memory. There's encoding, there's storage, and then there's recall, pulling it out of your head again. Yeah. And ECT can interfere with all 3 aspects. But more commonly, during the time of the ECT, when people get confused, they have trouble encoding. So you'll talk to people who've gotten 10, 12 ECTs. They feel fine. They feel fantastic. They have very little memory of what happened during the ECT course. And that's because they weren't necessarily encoding.
Yeah, that's very helpful.
Neuropsychological studies looking at people who had ECT actually show on average people's, executive functioning and other neuropsychological, neurocognitive functions actually improve with ECT.
Okay.
Yeah. When people start with the ECT, they're often severely depressed. And as you know, people who have severe depression have terrible executive functioning sometimes. They're so ruminative, they can't pay attention.
Yeah,
so there's actually on average an improvement.
Cognitive impairment,
cognitive improvement with the ECT on average. Now, and then, and so when you talk to patients, sometimes they'll say, yes, my memory is still terrible about ECT, but usually what they're referring to is their memory around the events of the ECT are terrible. Their actual current cognitive functioning is improved or good. So you have to ask them in a different kind of way. I often find myself asking, okay, so your memory around the ECT was not so good. How's your memory function now? So asking about the function as opposed to how's your memory, because people often kind of conflate all sorts of things with like, how's your memory now?
I see what you're saying. Okay, your function for the memory. And so they can then encode going forward, you're saying. It's just more proximal.
Well, once the confusion from the ECT has resolved.
I see.
And so when they do these neuropsychological studies, it's usually up to like 2 weeks after. By the time you're 2 weeks out after your last procedure, they have an awful lot of trouble finding any neuropsychological deficits. Like after an ECT treatment, the person's groggy, they're post-ictal, you'll see like they're not as sharp and stuff like that on these neuropsychological. But if you wait 2 weeks after the last one, they're really not able to find any problems. Now, having said that, these studies are not huge. These neuropsychological studies, it's like 4 8-hour batteries, and they have to do it before, during, and after the ECT, and no one's really paying a lot of money to fund these kinds of studies, right?
Right.
So they're not big studies. So I would say, every once in a while, I do bump into someone who says, I did ECT, and I functioned fine. I'm glad I got it, maybe even, but I feel like my memory's not quite as good.
Okay.
And it's hard to know about that. So when I talk to patients about ECT, I say that this is no guarantee. It's not 100% safe, but it's pretty safe. And so you have to weigh the risks and the benefits for each individual patient. And this is my gut sense. It's like maybe 1 in 100 or 1 in 50 patients will have like a phenomena where they say, well, I feel like my memory is just not quite as good. Yeah. But they can still do all the things they need to do.
Okay.
So.
Yeah, the way I think about it, sometimes when we think about risks of treatment, we often think about the side effects and the risk from the treatment itself. But something that you just alluded to, I don't think we talk about enough, is, well, what is the risk of inadequately treating the illness? And certainly with depression, people kill themselves and their lives are affected. So I think that has to be thrown in there with this relatively small risk that you mentioned. And so this leads into my next question, which has to do with misconceptions. Obviously, one misconception is you will fry my brain, and everybody has problems with memory. And I guess we've debunked that to some degree. Yeah. But what about other ones?
Yeah. Well, one thing to remember is it's a series of treatments. So it's very rare after the first treatment they have this complete amnesia or severe cognitive side effects. It's really much more it's kind of 3 times a week. It's building up over time. And so when we see that, we can begin to make adjustments too. Like we can go 2 times a week.
Spread it out. Yeah.
Yeah, spread it out. Lead placement, like doing bilateral ECT versus unilateral makes a difference as well. So.
Tell me about that. Is one more effective than the other, but more risky? Or how does that...
exactly. Bilateral is more effective, but it's more risky.
Okay.
So our standard protocol for our service, I think many other services around the country, you start everyone at unilateral. And then see how it works. Sometimes they work, many times it just works great and then you're done. Yeah. But sometimes a person, they've gotten 5 or 6 treatments, they're still not any better. Importantly, they also don't have any side effects. So they, and in that situation, they're not any better and they have no side effects. Then I'll go to the person and say, hey, listen, in this kind of situation, we're often going to bilateral. Would you be willing to give it a try?
Yes. And how do you pick which side to go to? Or does it?
It's interesting. When they did the studies we do everyone right unilateral.
Okay,
on the right side. The language centers are on the left. So the theory is when they did the studies that they compared left versus right, people who got the right side of the ECT could talk about 30 seconds sooner than the people who got left side of the ECT. But there was no change in the outcomes.
Okay.
It was just they could recover a little faster.
Does handedness matter? If you're left-handed or right-handed? Yeah.
Well, it turns out left-handers are about 50-50. Are they left or right hemisphere dominant.
That's
so
right. Yeah.
Theoretically, you could figure out are they left or right hemisphere dominant, but that involves like the WADA test. I don't know if you know this, but you have to you can inject the interior internal carotid artery with sodium amytal and see if they can't talk. That's way more dangerous than the ECT, you think. So you don't want me poking around your neck with a needle. That's not good.
It's just easier to do everybody right-sided. That's great.
Yeah.
And then has lead placement changed over the years as far as exactly, you're trying to get over the temporal lobe, I assume.
Again, I don't think it's changed that much. There's a couple of other, I think, lead placements that they all work pretty well. It's hard to show big differences between them.
Okay.
So even when we're talking about this difference between unilateral and bilateral, it's not a huge difference. I still think of ECT as being, it engages the entire brain. When they do these physics, mathematical modeling of the brain, even at pretty low energies that we use, you're actually getting depolarization of neurons on the opposite side of the brain when you're doing unilateral, even at the lower energy. It's enough energy to depolarize neurons throughout the brain. So,
Right. And this is different from TMS, which you're more stimulating just more proximally to the field, I guess, that you're in. Right. If I understand that correctly.
It's much more focused.
And
so that's good in the sense that you get less side effects. But then we get back to my shotgun versus sniper, my dad's shotgun versus sniper rifle metaphor.
That's right. Yeah. Are there other misconceptions about ECT that you see that people come in with?
I think most people worry that it's like painful and kind of barbaric, kind of a brutal procedure. Right. But I think that's the most common one. But people don't realize it's not like one flew over the cuckoo's nest. General anesthesia, muscle relaxants, you're asleep. You don't even remember the actual procedure.
Right.
Like I said, the IV is probably the most painful thing. Occasionally, people get headaches, and like I said, we can compared with suicidal depression, headache is trivial for most of the patients.
I agree. I guess another misconception would have to do with contraindications. You made it sound like there's actually not a lot of... So I guess, of course, if somebody has hypertension, that would need to be managed. You wouldn't do this in somebody with real bad hypertension. I guess, do you monitor blood pressure, of course, as part of the anesthesia?
It's a very safe procedure. There was a study done looking at, so each state has to keep like a running tab of all the patients who get ECT. So there's a study done in Texas looking at I don't remember exactly the numbers, but 5,000 or 8,000 patients who got ECT. And during that study period of 5 years, I think they had 30 deaths, which seems kind of a lot. But if you look at, compared to the general population, it was actually less than the general population.
Oh.
So,
and that was death from all cause. That wasn't death
exactly.
Okay.
A lot of our patients are older, so if you do the age-matched, death rates amongst older folks like that, you might get similar numbers. It's because patients are being monitored. I'm sorry, go ahead, Andy.
Well, some depressed patients suicide even if they're being treated. We know that. Sadly.
Yeah.
Yeah.
I mean, people are getting their blood pressure monitored during the procedure, their pulse. You see in anesthesiology in the pre-op clinic, and they buff up your blood pressure and pulse before you start the procedure. So you're being monitored really well. So the medical contraindications are very few.
Yeah. I have another question that I'm sure you get asked all the time: is what if somebody has a pre-existing seizure condition, an epilepsy, let's say?
Usually when they're on anticonvulsants.
Yes.
Right. So if they're on anticonvulsants, you have to do, it's a little bit of a tricky dance. It takes some experience because I'm not aware of any way to quantitate this. But you want to decrease anticonvulsants enough so that when you do the ECT, it works.
Yes.
But if you decrease it too much, then they will have a spontaneous seizure, which often is not as therapeutic. So also it's dangerous, obviously, to have out of the blue having a seizure. So.
Well, and I just realized, too, you also run a bipolar service. A lot of bipolar patients are on an anticonvulsant for their bipolar. So that's an issue, I guess, as well. You have to taper it down, I assume, or something like that.
You have to taper it down, but you have to be a little bit careful because if you taper them off completely sometimes too quickly, you can get problems. And also, there's a mild withdrawal. Even if someone's on divalproex, which is a relatively long half-life, if you stop them cold turkey, then their seizure threshold goes way down. So you have to kind of adjust for that over time. ECT in general is an anticonvulsant treatment. So what I mean by that is, as the person gets more and more ECT, their seizure durations will get shorter. It'll be more difficult for them to have a seizure over time.
So it's harder to induce the seizure, you're saying, as well?
I wouldn't say it's harder to induce. The seizure durations get shorter. And so if they get too short, then we worry, and then we try to make adjustments either with our stimulus, or oftentimes patients are on medications that we need to adjust.
Do you routinely increase the stimulus over the course of a treatment, or is it the same stimulus for all, say, 9 or 10 treatments?
We usually use the same. We try to do everything identical each time, but if the seizures start getting too short, then we'll start making changes.
That certainly makes sense. Okay. Well, that's really helpful. You and I had a little discussion earlier, as I told you I trained in the late 80s, early 90s, and I had assumed there'd be some evolution or changes, and you said not a lot, but how has ECT evolved over time? Have there been some evolutions or some advancements?
I think in 1980 was the time when all the machines were standardized.
Okay.
So we went to the kind of newer machines, which they're called, ultra brief pulse, pulse wave, and we started using general anesthesia for everyone starting in the 1980s. So starting about the 1980s, you get this significant standardization of the procedure.
Got it.
There have been some really interesting attempts at innovations, looking at different lead placements, and looking at other ways to stimulate seizures. But they're hard to separate from each other because I think it works pretty well, the treatment. So it's hard to show that one thing is better than another when you're getting a 50% remission rate already. So
right.
So, and if when the medical students come by and look at our ECT machines, it looks like something from the 1950s. They're really kind of old.
Yes. That's interesting. So the machines haven't shrunk so much over time, or changed in their look, not more futuristic looking.
Yeah, for any interested person in the audience, if they could make an app on your iPhone or something like that could do ECT, that would be awesome. It's not that much electricity.
Interesting. Well, I guess I would recommend, you just made me think of something. I would recommend that interested clinicians should try to make an appointment to visit an ECT suite or to talk with an ECT provider. Yeah.
We love that. I'm an academician, so I'm used to giving lectures, and so I'm happy to go to any local chapter and give a little talk if people are interested.
And I would assume you have students and trainees in with you when you do this?
Yeah, pretty much all the time.
Yeah. Okay,
we're training residents, geriatric fellows, and medical students. I just wanted to get back to the other common misconception, which was the brain damage thing. People are always concerned about, does it cause permanent brain damage? And as I mentioned before, the cognitive studies don't show any evidence for that. And there are also the evidence of in mice and rats, studies in them that they don't show any structural brain damage. And also in humans, we can't do the same kind of studies in humans that we do in mice, but you can look at now we have these fMRIs or these high resolution MRIs and look at different structural pieces of the brain. We don't see any atrophy of the brain or any parts of the brain in this. They're not huge studies, but I want to qualify that. But if any, they do show actually some volumetric increase in hippocampus volume with ECT. Again, these are tiny studies, but at least I would say that the evidence is pointing maybe it's better for your brain as opposed to the atrophy piece. At least the directional arrow. I wouldn't say it's proof, but at least the direction arrow is more reassuring.
Yes. Yeah. Well, what you're saying, of course, fits with our theory of neuroplasticity, and especially the hippocampus is one of the really dynamic areas of the brain where you can actually have neurogenesis. And one of the most consistent radiologic findings of depression is shrinkage of the hippocampus, fascinatingly. So that is an area to focus on, of course. Along with our kind of contraindications, what about using this in a pregnant woman? Could you do that?
Oh, definitely. It's a very, although I have to say it's not that common in clinical practice because, pregnancy is only 9 months. People are often willing to tough it out, but there's a lot of literature to support the safe use of ECT in pregnant women, especially when you're concerned about teratogenetic effects of medications.
I would think there's more risk with the anesthesia than with the ECT itself, although I don't know that the risk is high.
But it's very brief. I mean, anesthesiologists are pretty, it is a general anesthesia, so that's their more significant thing, but on the other hand, it's a 10-minute thing. So they're pretty, compared to the other procedures that they do, that maybe they're a little bit, they think it's like pretty minor, I think, from their point of view.
How about somebody with some dementia? We know there's a very big, there's a high incidence of depression in patients with dementia. Again, the concern here might be that I would do further damage or something, but is there a literature on this or your experience with this?
I think it works pretty well. The main issue is that it can, they're at higher risk for cognitive dysfunction.
Okay,
they're getting confused or something like that. So, I think one of the things, maybe you were asking about this in earlier questions, like one of the things we do is like, we don't have a standardized protocol for people. We monitor them really well during the procedures, unlike what you might see on TV in the past. And we also, we're much more sensitive to like if they're having side effects, should we cut back? Should we change to unilateral? Stuff like that. So
that certainly makes sense. Are there any medications other than those that would change seizure threshold? Are there any other medications to be concerned about or that would not be appropriate to use with ECT?
There's some literature on lithium increasing your risk of confusion with ECT. I mean, these mostly are case reports, but, and it's more common with patients who are at the higher levels. You got a patient at 1, with a lithium level of 1 or 1.2, they're going to get more likely to have cognitive side effects. So usually before the ECT, we tell patients who are on lithium to significantly reduce the dosage and then skip the day before, the morning of ECT or the night before, just so that the blood level of lithium during the time of the ECT is pretty low. There's so many different medications out there. It's usually helpful to, when you get your consultation from an ECT practitioner, make sure that they provide you with what to do with the patient's medications. Typically, it's just continuing them, but as you mentioned, there's some little like lithium, and there's a couple other little things that people should probably aware. But it's impossible for the typical average clinician to remember them all. They're not doing ECT, so they should make sure to get the ECT practitioner to answer those questions.
Yeah, of course, the big obvious ones are going to be, like we said, anticonvulsants, things that play around the seizure threshold. But I think one thing is, a lot of times patients want to hold their medicine the morning of a procedure, thinking they shouldn't take it. But I think we should probably say you want to take your high blood pressure medicine.
Definitely.
That's very important, because I'm sure there's a transient elevation in blood pressure. Am I correct?
Right.
During the seizure.
Thanks for the reminder. During the procedure, there's a transient elevation of blood pressure and pulse, and also intracranial pressure. Yeah, exactly. So for the vast majority of people, unless you have an intracranial lesion, that doesn't matter.
It doesn't matter.
And then the pulse and blood pressure, the anesthesiologist is monitoring them, but they don't want to overcorrect either, because the procedure is so short, the seizure is so short. So by and large, we just watch a person. Most people can tolerate a very brief increase in their blood pressure and pulse. So
back to lithium for a second, because you did mention it's useful in bipolar depression. This gives me an opportunity to plug our friend Jonathan Meyer's book, The Handbook of Lithium, which he published with Stahl, actually, in Cambridge University Press. And he taught me, he's a very good friend of mine, Jonathan, he's in San Diego, and he taught me that actually we are probably overdosing a lot of people with lithium by virtue of giving it BID. And that's because if you give it BID instead of the whole dose once at night, when you check that trough level the next morning, you're really measuring only part of the dose, because most of the morning dose has kind of, it's pretty short acting. So what you're saying makes a lot of sense, that it could be these people with higher blood levels, especially if their dose BID, are actually higher than, are being overdosed. And should we really give it all at night and get the trough the next morning? That's a more accurate level, perhaps. And this is part of the reason why BID has more renal toxicity, for instance, than once a day. Yeah.
I'll put on my bipolar hat now. But we advocate everyone to do once a day dosing of lithium because of the renal side effects. As well as, the issues that you mentioned about the levels.
Silly me, I was trained BID or even TID, and there was, as you know, a preparation called litho-bid, and the bid meant BID. So, this is newer information that some clinicians that are older like us may not know. So that's really helpful, and thank you very much. Now, I think what we've covered kind of the nuts and bolts to some degree, considerations. We've covered the procedure itself, but there still are misconceptions and stigma. And I think you've done a terrific job talking a little bit about how you speak to your patients around ECT. But for our audience, how would you recommend we speak about it before they even come to see you? How would you recommend we have the conversation to get our patient to accept this and to consider it?
I would just make a clear statement of fact, to saying like ECT can be a really useful treatment in these kinds of situations.
Yes.
And if you're the clinician in this situation, say it may be helpful for you, and try to obviously be open and honest, acknowledge and validate that ECT can be kind of a scary idea, and there's a lot of controversy around it.
Sure.
I would also emphasize that when they're referring to see me, they're not referring to the person they're going to come and get ECT. Patients often have this conception that, if I go see Descartes Li, that means I got to bring my clothes and get ready to do ECT. It's like, no, you're just going to come and meet with me.
Yes.
We're going to talk. We're going to provide you with some information. You're going to ask me questions.
Yes.
And it's perfectly normal to have questions and reservations around ECT.
Yes.
I emphasize I wouldn't do it if I didn't think it was really safe. And if I meet with you and I don't think it's safe, we're not going to do it.
Yes.
So
I think that's the key message. This is an extremely effective treatment that is found to be generally very safe and well tolerated. I think that's one way to sort of start this. There's two other things I want to discuss with the time we have left, if that's all right. I forgot to talk with you about how do you determine, once you've done the acute round of treatment, how do we determine what the maintenance schedule might look like, if a patient even needs maintenance? How is that all determined?
Again, it's a conversation with the patient. It's really, once you're getting into the maintenance, so let's assume the ECT worked.
Yes.
Then you're in this discussion of what is the risk of having depression come back, and what is the patient's risk tolerance? And also it's guided by your own opinion. Now, so for patients who've had long-term depression and they slide into it very gradually, you can, you have some time and you can get them back into treatment relatively quickly,
So
for other patients,
do you do a watch and wait strategy with those people, or is there a standard?
Usually I tend to prefer a watch and wait kind of attitude. Part of it depends on the service. We're pretty busy at our service, so we don't want to do extra ECT. There's been some studies looking at, if you do kind of a blanket protocol and do once a week ECT with every patient who's responded, you definitely do decrease the risk of a relapse, even if you just do it once a week for a month. But I think the number needed to treat in that study was something pretty significantly high. I'm thinking 16 or something like that. Yeah. So, if you're giving 16 patients 4 ECTs each, that's 64 extra ECTs that you're giving. Whereas, so this is my weird, public health way of calculating this. It might be better just if you could get that one person who's going to relapse, have them come back sooner, do ECT with that person, you're more focused. Now, that person though, who relapses quickly is now in our mind someone at higher risk and may be a candidate for longer term maintenance ECT.
Can you get away with once a month, or does it have to be once a week for maintenance?
Usually so there's this little technicality here. It's we call it continuation ECT. So when you're transitioning from the acute course, you have this continuation where you're doing once a week. Then you do maintenance would be once a month or even greater. We have a few patients who swear by once every 3 or 6 months,
Okay, sure. Yeah. So there are some people who are on a kind of regular schedule, and then there are some that are sort of the wait and see kind of approach. That makes perfect sense.
And the other thing is, even if we do maintenance, someone we did ECT, had a good response, they had a relapse a few weeks later, we have to do a few more ECT. We'll keep them on an ECT regimen of once a month, but we'll still try again to wean them off ECT, as it were. Sometimes you'll find if the person has not been depressed for a year, this is maybe my own hand-waving theory, the person has not been depressed for a year. Their brains are different than the person who's been depressed for 2 years and now just been fine for 2 weeks or a month.
Right.
Someone whose brain has been not depressed for a year, maybe there's something different, from a systems or, neuroplasticity point of view that I'd be ready to try again to stop the ECT and see if they relapse in that
Well, the
situation.
pharmacologic literature is consistent with that. We know that the highest risk of relapse if you stop an antidepressant is within the first 10 months to a year. So we usually recommend continuing treatment for at least 10 months to a year. That's even done in primary care because of that. So that makes perfect sense. Okay, the next thing I want to talk about, the field, I guess we're calling this field now neuromodulation, and I hope you're okay with that. That's not somehow inappropriate, but we call this field neuromodulation, and it includes ECT, TMS, and of course VNS is something being studied very actively, and I guess deep brain stimulation would come under that category. How would you say this compares to some other modalities, such as, I think TMS is probably the most common and the hottest one. Mm-hmm. How would you compare this to other modalities?
I think it's TMS is very focused, as you know, we were discussing earlier. So this is a little bit more like, this treats the entire brain, so we're more likely to get some effect. I think it tends to be a little bit more durable too. Yeah. So I think I had some similar kinds of comments about ketamine. Also, it seems like ketamine works pretty well, but it just doesn't last quite as long. And so
ketamine, there's no question you have to continue it at some interval. And it's very interesting how different individuals respond. Some people have to get ketamine every week. Some can hold a charge every 2 or 3 weeks. It's just very individualized. But we know that ketamine, if you stop it, patients, by and large, will relapse. And so maybe there's more of a commitment to ketamine than you would need with ECT. But my sense, as you're saying, is ECT is more effective than TMS in general, and maybe have more enduring effect. That makes sense.
Yeah, my ketamine colleagues tend to think of like ECT as maybe even being a little bit more durable than ketamine itself. So ECT being more durable. Yeah. So, it's interesting because I think there were colleagues in the past, and maybe even now, people ask me every once in a while, like, well, does TMS or ketamine scare you or put you out of business or something like that? Well, first of all, I'd be like, if we had a really effective treatment that didn't have the side effects of the rigmarole, we'd be pleased.
We'd all be happy.
Yeah. But having said that, we haven't seen a downturn in our referrals. If anything, a little bit more. And a lot of people have had TMS or ketamine already. And I think it in some ways decreases the stigma around neuromodulation. Like, if I do something with my brain, a lot of times the TMS or ketamine worked a little bit. Like they could sense, I just need a little bit more, something that's a little bit stronger. I don't know if that's the right word to describe it, but they're much more open to getting ECT because of that,
that certainly makes
prior
sense.
Experience with these other treatments. So I don't think this really, it's just, I think now we have more different options, which is really great for patients, actually. Yeah,
and again, to what we talked about earlier, I think stigma is decreasing. And people are realizing this more and more, the severity of this illness, and that we have to sometimes be aggressive in treating it. As we said, the risks of inadequately treating the illness are pretty great. There have been a couple studies recently done and published on looking at ketamine versus ECT. Most well-known recently was called ELECT-D, ELEKT-D.
Right.
And the primary manuscript was published by Anand in the New England Journal of Medicine in 2023. And essentially it was an open label non-inferiority design, and it basically showed that ketamine was non-inferior to ECT. And, it's very hard methodologically to compare such disparate modalities, I would think, and it's hard to blind, it's hard to control, but it's interesting.
Yeah, I always look at the, how do they do the ECT? Because that's the most variable in these kinds of studies. Some studies they've only done it for 6, they try to mirror the ketamine. So ketamine you do for 2 weeks, and then let's do the ECT for 2 weeks. But that's clearly not the same as the 9 to 15 treatments. So you have to look at that arm. And then given that experience, a lot of people who, in clinical practice, it's rarely ketamine versus ECT nowadays. Most people will actually get ketamine, at least here in the Bay Area. Many patients will actually get ketamine first, and then they'll do the ECT. the few people who do ECT first are the ones who have really severe depression and just want to go for the kind of gold standard.
Yeah, that makes sense.
And then also ketamine a lot of times is an out-of-pocket treatment that people are paying for.
That's well said. You're right.
So, and as you asked me before, which is insurance companies are more than happy to pay for ECT because it works pretty well, and it's a medically necessary treatment, I think, from their point of view.
And of course, as we said earlier too, depression is such a heterogeneous illness neurobiologically that I'm sure there are some people who may respond better to one or the other. So, looking at averages is a little bit misleading because perhaps for an individual, one is better than the other. So we need all these modalities, I think. As far as VNS, I'm fascinated that VNS is really not that effective acutely. VNS is more of a maintenance treatment. The effects accrue over time. And so some people are thinking now perhaps you do ECT or ketamine to acutely, with a TRD patient, to acutely get them better.
Right.
And VNS could potentially be your long-term maintenance, if you will.
I love that idea. There's also similarly with, they get an acute course of ECT and to prevent relapse, and they'll do TMS kind of thing.
Yes.
That's something that's under active investigation. That seems like a really good idea too, so.
Well, Descartes, I've been thinking about the analogy here. In other fields of medicine, we have like chemotherapy, we have induction therapy, and then we have our maintenance therapy. And certainly when you're treating bipolar, when you have an acute manic episode, let's say, sometimes we use higher doses and more aggressive combinations of meds. And then when we get somebody into stability, we might lower the dose or simplify the regimen. So it's not that unusual thinking.
Yeah, I use this metaphor. It's like sometimes when you're severely depressed, you're kind of in a rut.
Yeah.
Your brain is in this rut. Yeah. And it's harder to get you out of the rut than to keep you out of it. So they've actually done some studies with looking at I think it was paroxetine. So patients who had failed paroxetine got ECT, and then they were randomized to either stay on paroxetine or go on placebo. So this is after and people who stayed on paroxetine, even though it didn't work before, were much less likely to relapse than people who were on placebo after the ECT.
That's fascinating.
That's like the rut idea. It's easier to keep the person out of the rut, but once they fall in, they need some sort of thing to get them out of the rut,
No, that's super fascinating. I mean, as a guy who's done a lot of clinical trials over the years, I always talk about an acute study is does the modality get you better? And then a maintenance study is does it keep you better? And I hadn't thought about, usually I think about something that gets you better but doesn't keep you better. But what about the inverse, something that doesn't get me better but actually could keep me better? That's a fascinating concept. And so there again, ECT and then putting somebody on a medication, even if maybe they had failed acutely before, that's very helpful. Thank you. That's very helpful information. And it's very practical for our
interesting
audiences.
Phenomenon. It's like it doesn't. You have to think of some way to, how do we rationalize these interesting observations,
Well, that's why you do the studies, of course. But, I always say with our field, buried within, our studies are looking at averages of groups of patients, and buried within averages are always individuals. So I would say your mileage may vary, of course, with these treatments. Well, I have to tell you, this has been a fascinating conversation, Descartes, and I've learned a lot, and I think it's been extremely valuable for our audience. Are there any other final thoughts or anything else maybe we didn't cover that you think might be important?
If you don't mind, I'll just repeat,
Sure.
Stigma can be a significant barrier to ECT, I think, these days. So it's really helpful if the clinicians can mention it to patients in a kind of compassionate, educated way, helping them overcome their fears and, accessing what sometimes is like a life-saving treatment. It can be really important. By the way, if you don't mind, I'll put in a plug in for our, we have an instructional, informational sheet, FAQ, frequently asked question sheet. You can get it if you just Google ECT, UCSF, and FAQ. It'll bring you to our webpage, and people can, getting reliable information about ECT is not easy. Probably about anything, it's not always the easiest thing to do for patients.
No,
but
that's fantastic.
Pointing them to reliable resources and education can be really helpful. And just bring it up in a matter-of-fact way.
That's a tremendous idea. So say it again. I would Google ECT, UCSF, FAQ, something like that. That'll get you there.
That's it.
Oh, that's super, because I know a lot of our audience, we at NEI have started doing some medication information sheets for use with patient information materials, and they've been very popular. So I know our audience likes things like that. So thank you very much. I guess one other thing I would suggest is there may actually be some clinicians out there who have, especially newer ones, may not have been as well trained around ECT, may not have had as much experience. Perhaps they have some stigma too, or some reluctance, and maybe we need to help educate them, and certainly this podcast would help. But I'd like to recommend that they form a relationship with an ECT practitioner, visit an ECT treatment center, get more comfortable so that you're very comfortable referring your patients there.
Yeah. We don't want to be a black box. We want people to know what they're getting into, and we want to show people around. We're totally happy to do that ourselves. So I will just say, from the point of view of the ECT practitioner, the more education, the more open we are and make connections with people in the community, the happier we are. Makes our life a lot easier.
And that continuity of care is so important, of course. All right. Well, again, I want to thank you all for listening. For more information and about more of our educational offerings, and certainly more of our podcasts, you can go to our website, which is NEIGlobal.com. That's NEIGlobal.com. And you can certainly find our podcasts wherever you get podcasts by either searching NEI Psychopharm, or my name is the moderator, Cutler. You can always get them that way. So once again, Descartes, thank you for your time so much. This has been really a terrific discussion.
Totally welcome. Totally my pleasure too. Thank you, Andy.
You bet.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIGlobal.com.